There it is. Okay, so welcome everyone. This is the April meeting of our health policy SIG. So some news we have to share is that Nina Sperber has stepped up to contribute as one of the leaders of the health policy SIG and take over for me this summer. So thank you, Nina, and she's here today. So thanks a lot. And we've been working together to kind of transition her over the next few months. And then we also have another SIG meeting planned for next month already. So I will be sending information about that. I believe it is on like the first week of May. Hang on.
At a regular
Yeah, like May 8th, I think is what we're planning for, but I'll send out more information about that at a later time. So I guess without further ado, let's get to our speaker for today. So we have Claire Brereton. She is a research fellow at the University of Queensland Center for Clinical Research, where she is part of the Operational Research and Decision Support for Prevention, Control, and Elimination of Infectious Diseases group. As the group's first system dynamicist, she is spreading the word about the power and applicability of SD. She's also working with a team in Kenya on a project supported by the Alliance for Health Policy and Systems Research at the WHO. And today she's going to be presenting on elephantiasis elimination in the Pacific Islands, modeling scenarios for policymakers. So, Claire, without further ado, go ahead.
Right. Thank you very much. Let me just share some slides here and let me say thank you for coming to hear about these diseases in our part of the world. I'm not sure where everybody is from, but I'm assuming that there's nobody from the Pacific Islands here. So I'm pretty sure that we'll have an American and maybe a European audience. And I'll just see whether I can get my first slide up, and there we are. Is that looking good?
Great.
Right, okay. So what I want to talk about is a disease, I've called it elephantiasis because that's what most people know it as, but its clinical name is lymphatic filariasis. And essentially then this disease is all over the world in countries. Generally it's a disease of poverty, so it's in poor countries, but you can see from this title slide that the range in the Pacific with all the red dots is pretty extensive in tropical areas. And so I'm just going to talk about the disease for a bit before we go on to modeling it. It's neglected tropical disease which results in elephantiasis, which you can see from this pretty grim picture here, and I've certainly seen that in reality. It's a chronic disease once it gets to this stage with no cure at all, and as you can imagine, that causes severe disability, pain, and social stigma. There are 51 million people infected worldwide, which is quite a shocking number. And I guess that's why it's a neglected tropical disease, because those people are in disadvantaged and poor populations, and 600 odd million people at risk. What many people don't realize is that this disease is transmitted by infected mosquitoes, and it has a really, really long asymptomatic development time. So many people actually have this, and they never show the systems that you have here. So if I just go back to the title slide for a minute, you can actually see that Japan's an endemic area. They managed to eliminate this disease in the 1970s because, you know, they had wealth and resources. And you will also see from here that Hawaii, luckily for the USA, does not have the disease, even though it's kind of in the climate zone, because it doesn't have the right mosquitoes. It doesn't have a carrying vector. But in the US, you may know that Haiti and Dominican Republic are in the endemic areas as well. Okay, so we've talked about the disease and its effect. Let me just do a picture of how this disease gets transmitted. So we'll start where all the trouble starts, with a mosquito, and a mosquito infects, which is itself infected, would infect a human being by taking a blood meal. So that's for female mosquitoes only, because they're the ones that bite. The male ones just swan around drinking nectar and no trouble at all to humans. So female mosquito injects tiny larvae, we call them L3 stage larvae, through the skin, and they develop off, not always, but sometimes, into adult worms who are male and female. And those adults produce things called microfilariae, and those go into the circulation of the human body, and they actually come up to the surface into the capillaries at the surface skin. And then when another mosquito, or even the same one, no, it wouldn't be the same one, takes a blood meal, then that mosquito ingests microfilariae, and there's a complex process in the mosquito which involves in killing some of the mosquitoes as the larvae evolve, and there you go round again. So there's ongoing transmission through this bite mechanism. These things, I can just about pronounce it, Wuchereria bancrofti, are up to 100 millimeters long, so maybe 4 inches for a female worm. And in order for this mating to happen, then you have to have 2 worms, male and a female, in the same bit of the lymphatic system. So in the Pacific, the vector is Aedes polliniceus, and that's a different mosquito from that in other parts of the world, which actually makes it harder to eradicate because it's a day biter as opposed to an evening biter. So let me say, this disease is acquired through multiple infective bites, and for reasons that nobody quite understands, because there really hasn't been enough research, many people are uninfected despite the fact that they're imposed to bites every single day. Only a small proportion progress to that clinical morbidity, also unknown why. And the main tool we have against this is mass drug administration. So essentially, we are giving a cocktail of drugs on a population dosage basis, so a bit like a vaccine, but tablets. And because of what I described with the male and the female worms needing to mate, people can be infectious and can get symptoms. Sorry, people can be infected without necessarily being infectious, because you have to have a male and a female there, and you might get up to about 10 worms. That seems to be the limit of this. So an issue we have with this is detection of lymphatic filariasis. So it's tested in the community level first through these strips, which are a bit like the test strips that you use for many other diseases. You take a tiny pinprick of blood, and so we ask people to participate in surveys, and of course you never get 100% compliance, and that detects whether you have the antigens, which mean that you've been exposed to infections. So you find quite a lot of those. And then the only way to find out whether you have these microfilariae, the tiny little larvae, micro larvae, which the worms produce that humans can ingest. The only way to find that is to actually take a blood smear and look at it under a microscope. And so you find there's a ratio between the antigen positive people and the people who are actually infectious, which makes modeling tricky. And then, of course, if people remain undetected and they get to the stage where they show symptoms, then clinical diagnosis makes that fairly straightforward. So the problem that I'm dealing with is how we can eliminate this in Pacific Island countries. 80% of this disease is in Africa, and that's a huge problem, and we're nowhere near elimination there. But the advantage that the Pacific has is it's relatively contained islands. Sure, there's movement between them, but it's not as difficult as with the big landmass. But we're still struggling. So the main tool is mass drug administration, and you may see that on there we have ivermectin, which is became notorious during COVID, as you know, and it was actually quite difficult to continue programs in the Pacific because some of the use was being taken by people who didn't like the vaccines that many of us wish that they would just take. So there's mass drug administration, which actually kills these little microfilariae, sterilizes the worms. And the World Health Organization set some guidance 20 odd years ago, which said that if you can reduce the prevalence of these tested antigens via the test strips to 1%, then you should be on a track to elimination. But we know that doesn't work, and you'll see a bit of that from the modeling. So we are looking at the moment at various ways of reducing this with multiple rounds of mass drug administration. Okay, so from a modeling perspective, having given you a bit of a brain dump on what this disease looks like, then essentially you can build, this is a simplified version of the mental model, which as ever is pretty complex. You've got the place where all the trouble starts at the bite, where humans are exposed to mosquitoes, and mosquitoes are also infected by humans. And you have, I guess, the main reinforcing loop here, where you've got the mosquito bite introducing larvae, which develop into worms, and those worms then potentially mate and produce microfilariae, which then expose the mosquitoes. So that's a fairly clear reinforcing loop. We've got one thing which is good and stops the spread, and that's that the death rate of infected mosquitoes is much higher than the death rate of ordinary mosquitoes, because as these larvae develop, they can actually kill the mosquito. They have to break through the mosquito's digestive system into the thorax and actually get to the proboscis of the mosquito, where they can be injected into the human. So there's a bit of balance going on there. There's a loop here with mosquitoes. There's also a balancing loop with a human ability to become immune and to kill the larvae, and for the worms seem to stop the larvae developing after a certain point. So the infection just doesn't keep on increasing. So the mental model looks something like that. When I started looking at this, I wanted to try and figure out exactly how this worked. And what I ended up doing was building a general, simple model for mosquito-borne disease, which looks something like this. So you've got here human disease progress with 3 stocks in it, and you've got in here susceptible mosquito disease. So it would be different from the normal susceptible infectious recovered model that you'd see for any normal disease, and then possibly a return to susceptible as people lose immunity. So if you look at this, you'll see, as you'd expect, people flowing from susceptible to infectious, and people flowing from infectious to recovered, triggered by bite rate and number of humans and so on. But then also you have mosquito piece here. And the key of all this is that bite rate with the brown arrows going this way. And you can actually calculate from this R0. So this would be any sort of model. It could be something like dengue with one of the diseases where you get lifelong immunity from each sort of dengue. And if I look at this, I'm not going to run it here. There's a stack of maths there, which I won't take you through, apart from just one little piece, and that's that the bite rate gets squared in terms of the calculation of the R0, which is the transmissibility, the number of people one susceptible human will infect from a single infection. So the bite rate gets squared, so that becomes hugely important. I've actually put that model up on Exchange, the ISEE Stellar Systems Exchange. So if anybody wants to have a look at it and have a play with it and change some of these parameters and so on, you can see how that works. So I hope that will be a useful resource in this infectious disease space. Okay, just going on to dynamic model, it starts to look a little bit different from that, although based on that with a susceptible human population. But then you have two sorts of infected people here. You have, I've called them infected infectious and infected non-infectious. And these infectious ones are the people who are infected and can produce microfilariae, which will be able to be picked up by mosquitoes, and that's kind of driven by a probability of mating, which is about 30% probably, so it's quite low. So you have flows through the infected and non-infected mosquitoes, which then go on through the lifespan of this thing. And the time for a worm to become infertile is about 10 years, and then a stage which continues to produce morbidity, where people are potentially infected with post-fertile worms before they potentially recover and lose immunity and become susceptible again. If you do some mass drug administration and kill the little microfilariae and also sterilize the worms, then you accelerate recovery, but you also accelerate the losing immunity and susceptibility. So yeah, it's gets a little bit complicated, but because the dynamics of this thing go over 20 odd years, then it's a really long time that you have to model this for. 20-year plus life cycle. I think I'll just skip past a mosquito model. I've actually had to, because of the times in this thing, I've made the mosquito I haven't got the other mosquitoes infected stock. I've made it instantaneous because it was just a bit too hard to model with the infected in there, but it's the same sort of effect. The model is more complex than this, and I promise I'll stop showing you model slides soon, and we'll go on to some results, because for each stock, then we have to have various flows changing the population. So the susceptible stock has a whole pile of flows going in and out of it. the first thing I want to point out is that people are born, and you don't have a closed population like you would have in a simple model. So you've got births coming in, and people will age through 10-year groups, and the stocks in here are arrayed by age, gender, and county, or even possibly a lower level within a country, and the population ages through, and people move from one place to another. So that probably makes when it's at the moment about 500 kind of compartments in the array for every single stock that we have. So yeah, I'm actually amazed it calculates as fast as it does, considering all of that. So yeah, an arrayed model. And I talked at the beginning about elimination in the Pacific. So what I'm doing is working with one particular Pacific island country at the moment as a starter. Now, the Pacific island country is super sensitive about this. So unless you can it depends how hot your Pacific country geography is, because you'll be able to identify it from a later slide, but they're not prepared to have it talked about because this disease is an embarrassing stigma for them. People do not particularly want them to know that they have this disease in their country. It's a bit of a stain, a bit like leprosy, actually, which is another neglected tropical disease, which is prevalent in many of these countries. So this particular Pacific country, we have a fair amount of surveys, and we have a fair amount of information. So I've kind of coded up the model. You might have seen green and yellow converters in there, and so some of the things I'm confident in, others I'm less secure about, so I've kind of colored those in, and we know some things, some probabilities and some lifespans and so on from the and those will be relatively similar across every country. The country specific stuff, we have history of prevalence and infection rates across the country, and we know when we've tried historical control, but we've got some key gaps, and probably the biggest one is the understanding of immunity. So if we look at this particular country, we can see that there were surveys in 2000, and going through all these kinds of times, and there was some mass drug administration, and there were some surveys in schools as well, which were pretty useless, but they thought that they were a good idea at the time. So we have quite a lot to calibrate against, although data is really not terribly good, but they've tried. We've got something to work with. Results, of course, calibrated, and you can see that there is lots of sensitivity, in particular to bite rate, and also to infection resistance and so on. If I look at this country, then this would be a typical chart that I would see. And so if we're looking from 2000, when we did the first rounds of mass drug administration, first thing I'll point out is these spikes. There's 6 of them there. Mass drug administration went on in this country from 2000 to 2006. And that was on a 2-drug regime, which was only about 40% effective. So that's kind of shown there. Then a better drug regime got introduced somewhere around this point. And so we've got a more effective drug regime from 2018 or so. You can see antigen prevalence going down, and then climbing up again when they stopped, and then going down, and a trail here which shows the what I think is going to happen. And here's some community survey results that we're calibrating against, and you can see that if you look at the actual people infected, you have a similar pattern, but this is with the microfilariae, which you can test for with a microscope, and you'll see that there's a much steeper drop because the administration actually kills, stops the infection. People's antigens hang around for a little bit longer, which is why this is smooth in here. So you can see we have some numbers there and some results. But if we start looking at 2010 forwards, then this essentially is a repeat of what I showed on the antigens, just a shorter time scale. And you can see here, this green line is World Health Organization elimination guidance. So what the WHO says we probably achieved in about 2022, but it is nothing like low enough to actually stop transmission going through. If, for example, we put some rounds of mass drug administration in, then we can see that you can reduce that and keep it low, but 3 rounds would not be enough to be able to keep that thing to eliminate, because all it really takes is one infected human, and you can start the cycle again, although it will take a while. Results are presented in the Stellar interface. So I love the Stellar interface. I think I'm their biggest beta tester, because I use it and keep finding issues with it, which to their credit they fix very fast, but I'm certainly pushing the capabilities of that thing. And you can see that I have on here kind of ability to put on some drug results, and I need to put on a few more from here. And you can see also that I calculate the initial reproduction number of this thing, and I reckon it's about 3. So one infected person will infect 3 other people over their lifetime, which is why it's so difficult to shut down this thing, because you've got limited tools for reducing that reproduction number. So if I look at model prevalence, these are different scales here, but this is a community survey from 2016, and I just wanted to show you that in terms of my age ranges, that I've kind of got more or less the same shape, with an infection peak around the 40s and 50s. Far higher prevalence in males than in females, which is thought to be partly lifestyle, more men working in the fields getting bitten, but also some kind of genetics which people don't properly understand. They think that possibly pregnancy seems to protect women in a way that people could do with more research. So I did say that this thing was calibrated to a county level within this country. And if I look at those same scenarios with no intervention after 2021 and 3 further rounds of mass drug administration, you can see that here's various counties. There are some hotspots in here. The outlying islands don't have any of this disease, which is why they're a lovely clean light green color. And so you can see that by the time you get to 2040, this particular is spreading again, but with those 3 rounds, you've still got a county which is more infected. So you can see that this is the trajectory for coming back. Getting to the end of slides now. This thing never, of course, ends. We all know a model is never finished, and still to do in this modeling is a stack of work. Because we have found that the transmission is highly heterogeneous, it would really be useful if this model was taken to lower level than county level. So I've actually done, I'll come back to that slide. I've actually just started on disaggregating to village level. And you can see here, there's a couple of hotspots around here on the on the northwestern coast of this country. This isn't right because this, I've got to go figure this out, but I thought I'd put it in to show you where I'm going with this. And this enables quite a lot more precision in figuring out maybe some treatment regimes. So you can get the hotspots standing out. One reason that this is so heterogeneous is that these mosquitoes only fly about 100 meters. So there is a very much increased risk of transmission if you live in a house with somebody infected or next door to somebody infected. So there's that's one thing to do, get it to village level. The next thing is to try and get some more precision on elimination. Of course, if you do a population model, which this is, then by the time you're getting to low levels, you've got lots of small bits of people. You've got 2% of a 19-year-old, and you've got 5% of a 25-year-old. At some point you would have to put in some logic which says once the people get who are infected get under a certain level, then you've got a pretty reasonable probability of actually making this thing die out, because your basic reproduction number isn't changing. So, if you have one whole person who's really infected, then gradually this thing will start up again. Yeah, there's more discussion to firm up uncertain parameters. I've got some mosquito control interventions, which are very difficult to achieve in Pacific Islands for a number of reasons. I've got some interface work, and as soon as I present this, I get requests to do it for a particular country, another country, and so there's a lot of ongoing work in here. Right. Okay. I do have a slide on comparison with other models, but I might come back to that if we have time after discussion. I would like to acknowledge my wonderful team, and in particular Dr. Patricia Graves, who knows more about mosquitoes and parasites and this disease than anybody would want to know. And I want to acknowledge some key models, a mathematical model and an agent-based model, which have been very useful. So let's just go on to discussion for a minute, and then we can come back to those slides if we need to. I might just stop sharing so you've got, if I can find, the tool. So you've got me to see while we have discussion. Now I can go back to slides if needed. Thanks for listening, and over to discussion.
Thank you very much. I'll go ahead and speak up. I've been wanting to ask more about mosquito eradication, which in some places has been very, very effective. Maybe it's simply the weather, the type of mosquito, I don't know, but I've been to tropical countries over many, many years where they have eliminated mosquitoes, essentially. And that has really helped lower disease transmission. And I just wondered, you said it was really difficult, and I can believe that it is these spread out populations. But with that short travel range, it feels like it might be possible.
Yeah, I think so, and I think that there might be there's some kind of cultural things here. I mean, people don't necessarily see mosquitoes as a problem. I mean, the number of bites per year is astonishingly high. I mean, it's in the hundreds, or some people estimate thousands, with these things just biting all the time. In the Pacific, it's doesn't tend to be the kind of swamps that you can go and spray, or larvicide, which are techniques that you can use in some other countries. They tend to be lurking around in banana trees and things, and it's a very individual eradication effort. But yeah, I really think that we ought to do something on eradication. The other thing, of course, is you can't just do a one-off effort, because if you model that, then sure, you can halve the proximal mosquito population in one hit, but the lifespan is very short. They breed very quickly, so you would have to keep doing that over a number of times. What else is difficult about it? The more tropical you are, then the quicker the development of the larvae within the mosquito. So the longer infectious lifespan it has. That's why we don't get these diseases in even subtropical places. But yeah, I agree. And of course, it's a disease of poverty. It's called neglected tropical disease for a reason. So that means that the resources to do this stuff are not as much as you want. So for me, I absolutely agree that a comparison between the Mass Drug Administration, which has really been the tool since the World Health Organization declared that that was the way to go. I think that we have opportunities to show, combinations of that plus some mosquito eradication as well, or more targeted drug administration. I mean, doing the whole country is great, but expensive, and I actually think we should be doing test and treat type interventions in particular hotspots, which you can see from the model more, and then you can get a little bit more precise on the thing. But you can't ignore the one infected person who's not in a hotspot. And of course, in this particular country, then 20% of the population work at a particular tuna cannery, so they all come in there, and that's a massive area for transmission as well. So yeah, clearing mosquitoes around there, I think, would be a go. Yeah. Okay. Thanks. Does that answer your question? Yeah. Great. Anybody else?
I have a couple questions. First, thanks for the presentation. It was really interesting. I'm formerly a clinical microbiologist, so I've always been very interested in like environmental infectious diseases, and they were my favorite to learn about and memorize all the life cycles back in undergrad. So this is like dusting off some cobwebs for me.
You probably know more about it than me then.
Oh, I haven't thought about it in a long time, so.
Okay.
But one question I have for you is like considering, data quality issues, especially in these sort of low resource settings, have you incorporated in your model any means of like accounting for underreporting?
For sure. I mean, so if you go back to the tests, I mean, we're not assuming that you can test everybody. So if you look at you go around, and the test teams are basically doing house to house door knocking, and then trying to get people to be tested, and the report, the rates of people who will or won't consent to testing are recorded, and so there's statistical manipulation, so you can basically figure out who's overrepresented and who's underrepresented, and you can see in the surveys the adjusted prevalences and so on. And I think that when you look at it, then the people who you most want to test are the people with the lowest uptake. And then you also, of course, have people who will consent to a fingerprint test to do the test strip, the first stage, but then refuse to have a greater volume of blood taken to do a slide. And then the people who are positive and won't do a slide are also an issue. So there's an obvious need for more awareness and education. I mean, I think that people in Pacific Island countries, they understand some things, but because of the long lead time, I think it can be very difficult to convince a young man that they may be part of the problem rather than actually and developing this morbidity. So it's it just needs focus and work, and it's competing with a lot of other things. One problem is that the morbidity is, as I said, relatively rare. It's certainly maybe only 10% of those infected people, but if you do have that morbidity, it's a terrible thing. I didn't focus on hydrocele, but I focused on elephantiasis or lymphedema, which can happen in other limbs as well, and hydrocele, which is a gross enlargement of the scrotum. Sorry, guys, and it's you can see some of the pictures, and that actually is operable to a point. Whereas the lymphedema, the elephantiasis, isn't operable. But again, in low resource countries, many men just live with that, and that is actually much more prevalent than the elephantiasis, which it may not be so visible, but in endemic countries like Papua New Guinea, then you will find about 70% of men who are 50 plus have that to some degree. So yeah.
Yeah, I imagine very painful also.
Absolutely, and socially stigmatizing affects economic participation, and there are comorbidities with diabetes and many other diseases. So and people have a lot of people in developed countries don't know that this disease is mosquito transmitted. I mean, the people on this call may have known that, but many people just have seen pictures and think it's some kind of genetic thing, or don't know where it comes from. Yeah, it's something that just needs education. I can see that there is a message in the chat here.
Yes, it looks like
Right.
the question is, did you account for treatment in your SIR model, which,
Yeah,
go
so
ahead.
yes, I might just share again, actually, if I can. Where are we? So
So I have a few questions about your model. So
yeah,
you have the disease life cycle.
yeah,
So obviously you have some tools, not perfect set of tools to sort of combat the disease
yeah,
with the MDA. But
yeah,
then you need to get the microfilaria, if I pronounce it correctly, burden down
yeah,
low, right? So that when mosquitoes come along and they're just vectors for the disease, from what I understand, and
yeah,
the hosts are the humans. So you want to get the reservoir, the humans, to not have any of the harmful parasitic materials in them. What like it doesn't look like the MDA by itself. You said one infected person can start the whole cycle again, and you can't figure out
yeah.
how many people are still infected. You're trying to get everybody, so to get a whole population covered with an MDA is problematic. So the question is really around some of the social aspects of it, educational aspects. Have you thought about modeling in? Is there policy resistance to MDA, or is it just it's just a supply problem? You can't get the whole population covered, so that you get 100% coverage. Obviously I looked up a little bit. There's some side effects from the medicine, but it doesn't look too bad. The treatment regimen is like once or twice a year, so that's
Yeah.
pretty non-burdensome. Because I've worked on chronic diseases and having adherence over long periods of time is really problematic. For example, so
Yeah,
so looking at the social side of it, that's
sure.
in the equation, that's not really modeled here.
No, no, but yeah, it could certainly be taken account of in the model. So the cocktail of drugs, and I can't remember the three of them. As I say, one is ivermectin, which is the best known. And there's another three, and they are considered to be almost 100% effective at killing the existing microfilariae and also sterilizing the worms. So if you could get all of your population to take them, you'd be done, basically. And compliance is something like 75%. Yeah, there are minor side effects, but they don't give them to children, I think, under 2 years old. They don't they exclude pregnant women as well because of side effects. So I guess the question is, are socially, yeah, I mean, we try to educate people, but there's a lot of work to be done to make this thing more effective. And it's in terms of the policy, then I think the countries know, and this particular country kind of knows that it has to do something about this disease, despite the fact, oh, actually, maybe this country doesn't because it's below the World Health Organization level, but a neighboring country certainly knows that it has to do something, but just is juggling and can't find the resources, and that has far higher levels than this particular country. So I'm not sure I've answered your question, but yes, those things are aware for sure. We could do something about them in the model, and you could put in, education, increasing MDA coverage, and so on, which would all help to increase adherence. But yeah, we have a range of tools at our disposal, and we haven't cracked the formula yet. I mean, some countries, as I think I said, Japan eliminated this in the 1970s, one of the first. China, on which the World Health Organization guidance is based, eliminated our late 90s, I think, and they would have done it through MDA alone. They're probably fairly good at enforcing compliance, I suspect, in the areas where they had issues. And I think also the mosquitoes did not tend to be the 24-hour biters, which makes a huge difference. I mean, so that's one of the things that that makes a big difference in terms of where your limits need to be. If you can just keep people secure and safe at night most of the time, then the bite rate goes way down. I can put the model up, if we probably haven't got time to put the actual model up and play with it in real time, but a relatively small decrease in the bite rate, because the impact of it is squared, means that you have a very significant decrease in the the transmissibility of it. Does that answer the question?
Yeah, I mean, I was trying
Yeah.
to figure out where the limits are to the interventions in terms of eliminating. You said some countries have been able to do it, so they
Yeah.
had something, either sufficient resources and probably public will
Yeah.
to be
Yeah.
able to accomplish the goal. So these
Yeah.
other countries are falling short of the goal, and then they're going to continue to have these, endemic. The disease is going to be endemic, and it's going to
Yeah.
have flare-ups, right? You're going to have recovery of the populations, and the populations get reinfected, and then the whole cycle continues.
Yeah.
Uh,
Absolutely.
so
And
there's something in their political systems, cultural systems that are probably, and maybe economic systems too, that are limiting their ability to get past this.
yeah. Absolutely, they are. Yeah, and you also see in the Pacific Islands, if I went back to that first slide, intro, I think. Yeah, then there are some countries in here. We'll pick Niue, for example, tiny little island country, which has eliminated, but the World Health Organization language is quite complex. It calls it elimination as a public health problem, which doesn't actually mean elimination to you or I. And so what they have to do is post elimination surveys, and of course so this particular country has just found a few cases. So what that means is it got to a low level where they thought it ought to have petered out, but it's coming back again. And as I said, I've looked through a lot of academic papers and I haven't seen anybody who's calculated the reproduction number before. I don't quite know why, because I would have thought it was an obvious thing to do in terms of understanding why this thing is so persistent. So I think I'm the first person to have actually done that, which is it doesn't help get the disease away, but it helps understand why it's so problematic.
Are other countries worried that if there are populations, that if those populations migrate to the other countries, they'll have a transmission of the
Of
disease?
course. Yeah,
So
absolutely.
how do they prevent someone coming from that island in whatever Niue to coming if they have the disease and they want to travel someplace? How do you prevent them from traveling?
Well, they don't have a requirement for some kind of negativity
Okay.
as an entry requirement. They're just basically trusting to luck. So I mean, there is migration between some of these countries which are closer together for work and family and so on. Some of them have closer ties, and they are worried. And I presented on this yesterday, and I was asked to do a piece of work to model another country, and then to also put in some kind of links and show how the one country affected the other country's chances of reaching elimination and staying eliminated. So yeah, it's an ongoing problem, because antigen positivity doesn't necessarily give an infection positivity. So you can't just the only feasible thing to do will possibly to do antigen testing, but you can't deny somebody entry to a country because they test antigen positive. So it's yeah, that is an intractable problem that we need to that I don't think we can do too much with, apart from just work on eliminating the disease in as many countries as possible and reducing the scale of the problem. And then, of course, we've got Africa. As I said, I haven't even touched on Africa, 80% of the global burden. And, that is something that we need to do some we need to figure out some strategies for there, but they have so many other problems. I mean, in the your part of the world, then Dominican Republic and Haiti are also endemic, and Haiti in particular, because it's poorer than Dominican Republic, has a bigger issue with it, but it appears to be quite difficult to work in there. We had some researchers from the Carter Center, which is in Atlanta, who've done a lot of work in Dominican Republic. So it was very interesting to hear their experiences, which are quite similar to what happens in the Pacific in many ways. Somebody, Douglas has raised
Douglas,
his
yeah.
hand.
Oops, hello.
Hi.
There's an awful lot. It's a great deal to take in here. So it's really
For sure.
a fascinating model, and how you've got you've got sort of two kind of templates that we're vaguely familiar with, the SIR model, but it's more elaborate than an SIR model. And then, although this is not a predator-prey model, what it has in common with that is that it's got two different species who have this relationship.
Yeah.
And a few minutes ago, you were showing us a stock flow diagram, which was a simplified view of the model. And
Sure.
being a fellow Stella user, what I wondered was whether it would be possible to superimpose small graphs of each of these stocks actually on the stock, and then run the model in short steps so that we could see that this is going up and that one's going down, and why it is, just as a way to get into the model's dynamics. And
Yeah.
I mean, just basically thank you for sharing your expertise on this subject with us, which is really quite well, impressive doesn't really do it justice. I thank you also for giving us the link to the Stella model, which I'll look forward to having a look at.
Sure. So the model I've put the link to is just this little mosquito-borne, the general one, because I'm not in a position to share a calibrated model from this particular country yet. But I mean, what I do want to do is to get their permission to put it up on the exchange, because apart from anything else, that gives policymakers and stakeholders in that country the opportunity to experiment with it as well via the interface. This one, and you can see the exchange. If you look up Claire B on the exchange, you'll find a number of things that I've put up, but this is the latest one, and that is just the very the basic thing, which works for any not for any vector but for a mosquito-borne disease. I mean, there are plenty of vectors which don't rely on a bite to transmit, but anything which is bite transmitted, like leishmaniasis, which is black fly transmitted, and so on, will all work on this kind of model.
Claire, if you wouldn't mind, could you
Yeah.
email me afterwards the link,
Of
and then
course.
I can share it with all the SIG?
For
That'd be
sure.
great.
Yes, I can do that. Yes, of course I can.
Awesome.
Yeah.
Well, I think we're about out of time, so I want to thank you again, Claire, for coming and presenting. I know you gave kind of a abbreviated early talk on this a couple months ago, which
sure.
was first sparked my interest. So thanks for giving us a more in-depth look. Yeah, so I'll just wrap up with just a reminder again that our next SIG meeting is going to be on May 8th. And that should be very interesting talk from Mohammed Jalali and Zainab Hazgul from Harvard. They're going to be talking about the sort of short and long-term impacts of cuts to NIH funding in the US. They've been doing some SD modeling work on kind of trying to characterize all of that. So that should be a really interesting talk and hopefully discussion next month. And then I also want to say that we don't have any presenters yet lined up for June. So if you or anyone you know has something that you'd like to present on, please email us. I'll just put our email in the chat. And I think that's pretty much it. So thanks again.
Rachel, this is Nina. There is one comment in the chat, a question that we didn't get to.
Claire, very nice presentation. Thank you.
Oh, my pleasure. Thank you. It was
Right.
good to be able to share this stuff, because sometimes you don't think anybody else cares about it. There is a question in the chat.
Yes, thanks, Nina, for pointing that out. I missed that.
Sure, yeah.
I think that person left,
Okay.
but
Right.
I will just, if you want to maybe copy that person's email. Looks like they might want to get connected because they're also working in Africa,
Sure.
which I think would be great.
Yeah, absolutely. I'm working
I'm
in
gonna
Africa
copy
as
I
well.
will-
I mean, I have a whole,
Yeah.
I have another life working with Kenya and their community health workforce, trying to figure out best use of that, and that's a system dynamics thing as well, which is a whole other presentation, but that's not really advanced
He
enough
says
yet.
he's still here in the room.
About.
Oh, okay, great.
Oh, okay. Right.
Why don't you go
Sorry.
ahead, if your microphone works, go ahead, Mayaba.
Yeah.
thank you so much. Thank you. I have limited internet services, so I couldn't switch on my video for me to be audible. I'm just learning systems dynamics, and I've been interested, and I've been following the presentations that are being made. My question is on the presentation on these islands. To what extent are they consistent in terms of mass drug administration to probably model the path for elimination as a public health problem? So the challenge that I've seen from low resource settings like where I am here is issues of consistency, and prioritizing NTDs is not as much as other infectious diseases like HIV. And so as a result, you tend to make 2 steps forward and 1 step backwards, retarding the universal global health agenda 2030. So to what extent are these islands consistent in terms of MDA? Thank you.
So I guess the easy answer is they're totally inconsistent. I mean, they're all different countries with governments and priorities, and they all have low resources. They're mostly lower middle income countries. There are a couple of least developed countries in there. And there are great differences between countries, and